We are live.
Okay. So, good evening, postgraduates and the members of AIOS. Welcome to this 124th episode of All India Online Postgraduate Teaching Program, which is an initiative from Academic and Research Committee of All India Ophthalmological Society. We are proud to say, till date, in last 2.5 years, we have completed 124th episode, and on the following Wednesday, following Thursday, we will be having our 125th episode, and we are going to have the celebration for that same event. So this particular today's thing is going to be on diagnostics in ocular trauma, and we are fortunate to have Dr. Saravanan, who is the professor and head of the department at Arvind Eye Hospital, Coimbatore, who will be speaking on diagnostics in ocular trauma. We are also privileged to have senior discussants Dr. Neeraj Sanduja, Professor Sunil Kumar, Dr. Colonel Pradeep Kumar, and Dr. Shubham Malpani as a discussants. So, without much ado, I would request Dr. Srinivas Joshi, our member ARC from South, to carry forward the proceedings.
Thank you, Prashant sir, for that wonderful introduction. Guys, I think it's a history that we have made 124th episode, the one which we started in our new tenure when Dr. Prashant sir took over as the chairman ARC. We had a huge discussion as what best we can do for our postgraduates, and we thought that we'll come out with the four format. One is the discussion of the long case and the short cases. The second one is how to interpret, especially when the OCTs are given, when the HES charts are given, when the glaucoma charts are given, when the FFA, ICG, all these things, perimetry charts, all these given, because some of the medical colleges do not have all these equipments. So that was the reason that we thought we should give a chance to all our postgraduates across India to how to interpret these part of things, to learn from the experts. And then we had the journal clubs. The recent cases, the recent case studies were taken up, and the gist of that, the Saransh is what Dr. Gabankule had also termed it. We started that. We had in a four format every week one thing, so that we complete the whole cycle of the short case, long case discussions, and with the how to interpret the charts basically, and then the journal club. So these four things were taken, and every month, and I'm very happy to see that it has reached 124th episode. Thank you, Dr. Prashant sir, for something which we all planned as ARC members, and he executed it so well. It's our baby. It was our all baby, and then he made it so successful that it has now reached to 125th episode. So without wasting much time, I think we have the doyens in the field today. Dr. V.R. Saravanan sir needs no introduction. He's a very high volume surgeon. And even at the end of 8 o'clock, after doing around 20, 30 retinal surgeries in a day, he still keeps smiling. I don't know what gene defect he has, but still, definitely we would love to copy his style, emulate his style. Thank you, sir, for joining us today. And then we have excellent discussants, Dr. Neeraj Sanduja, sir, who is sitting in the ice cold. He was just discussing with us that he is at around 2 to 3 degrees and still, waking us up with the warmers. Thank you, Neeraj Bhai, for joining us today. And then we have Professor Sunil Kumar, sir, who is the director of RIMS. Thank you, sir. Thank you for joining. And then we have interesting, a very dynamic surgeon, Colonel Dr. Pradeep Kumar. He is the professor and veterinary at the military hospital in Pathankot. And then we have another youngster, a dynamic youngster, Shubham Malpani, from Malpani Retina Care and Eye Hospital from Akola. So I think these are the discussions. So we'll have a topic on ocular diagnostics in ocular trauma by Dr. V.R. Saravanan sir. And then it will be discussed by all our four discussants. So it's going to be a 25-30 minutes talk from now on, say it's 8:05. So till 8:30, 8:35, Saravanan sir is going to talk, and then 25 minutes we have for discussion by all our discussants. Thank you very much. Enjoy the learning. So over to Dr. Saravanan sir, please.
Thank you, Srinivas. And first like to congratulate Prashant sir on his exemplary work in this direction. He's done a lot for PG teaching, and I hope he continues to carry on this good work in the coming years. I hope my slides are visible.
Yeah.
Okay. So as you can see, ocular trauma is a very common day-to-day occurrence, which is one of the common indications which you see in your day-to-day practice. And if you go by the global numbers, it's approximately 55 million injuries, causing approximately 1.6 million blindness all over the world. And it's one of the commonest cause of monocular blindness all over the world. It's in spite of the eyeball being shielded by the bony orbit all around, it is more vulnerable in the temporal aspect as well as the inferior aspect, which can be a cause for injuries. And even seemingly minor trauma can have devastating consequences unless it is diagnosed early and treated early in case of any issues. So before we start assessing the eyeball itself, when you're consulting a physician in the OPD and the patient comes with trauma, so always make sure that they don't have other life-threatening issues in the body, because the polytrauma is one of the common things which you see, and trying to focus on the eye can sometimes endanger the life itself. So always, depending upon the protocol professed by the ATLS or Advanced Trauma Life Support Protocol, always make sure that life before eye. That is, first you have to remember that life comes before the eye vision itself. So always first assess for other trauma which can be life-threatening, and that has to be taken care of first before you start treating the eye. In case of ocular trauma, in case you have other polytrauma and you are referring the patient, always try to put a shield over the eye, so in case of open injuries, so that the eye is protected till the other life systems are taken care of. So the importance of accurate diagnosis in ocular trauma is very important, because you can easily miss open globe injury, especially when it is occult scleral tear, or it can lead to delayed retinal detachment. And in trivial penetrating injuries can sometimes be missed, causing endophthalmitis. And sometimes timely management of these cases can lead to medical legal issues if you're not taken care properly. When you see trauma, they can be divided into four things. One, it can be where there's a breach of the ocular cords, which you call as penetrating. And when there's a blunt injury where there is no obvious breach of the ocular cords. And apart from the eyeball itself, the orbit also can get injured, like the floor fracture. And also sometimes you can have injury because of chemical or thermal burns. So when you look at injuries, you have to make sure that if it's a closed globe injury, whether there's a contusion injury, or that can be a lamellar laceration, especially of the cornea. An open globe injury, when there's a blunt trauma causing dehiscence of the ocular cords, we call it as globe rupture. When there is a single penetration, we call it as penetrating injury. When there are two anterior and posterior entry and exit injuries, we call it as perforating injury. And when there's a retained intraocular foreign body, that will be termed as it is. So classification, why you need to classify is that when you do this assessment and classify, it tells you to, gives you an idea of what are the investigative modalities and imaging choices which you have to make to further assess the extent of injury. So a proper history taking is very important, so that you can at least get, even though patient, the sometimes hidden eye findings can, once you get a proper history, you may be able to direct your area of focus and examination towards the that part where you feel that from the history that's the area to focus. So, like you have to take regarding the type of injury, how mechanism of injury, and how long since the injury occurred. Did he use any protective gear? Sometimes the eye itself may not be directly injured, but suppose he's wearing a protective glare or glasses, the glass itself can break and cause injury with retained intraocular glass particles. And whether there was any previous cataract surgery, in those cases, the most common area to tear is the section of the, especially this scleral tunnel where you make the for SICS surgeries. And when there is unexplained vision loss, you have to worry about either intracranial injury or optic nerve injury. So when you look at the patient itself, before going for any other investigative modalities, first you have to look at the patient, the eye itself in a proper way, right from the anterior to the posterior segment. So look at the first, you check the vision, because presenting vision can be an important prognosticator for the final visual acuity of a treatment. Always look at the pupil in case the pupil eye is not, the anterior segment is not too much damaged. It will give an idea of whether the optic nerve is still viable or not. And always look for the extraocular movements, because sometimes blowout fractures can have impingement of the inferior rectus in the floor fracture, causing movement disabilities. And infraorbital anesthesia by just swiping a cotton over the lower part of the lid can give you an idea whether there's a risk of occult floor fracture. And also in optic nerve injuries, you can always, or in retinal detachments, you can do a confrontation fields to give an idea of whether there is any damage to the retina or the optic nerve. So then you move on to your slit lamp and indirect ophthalmoscopy, and tonometry, avoid if there's a obvious open globe, open wound, and can be done later. If there's no open wound, then you can assess the intraocular pressure. So that if the intraocular pressure is low, that means that there is either a cycloidal, a cycloidal cleft or a ciliary shutdown, or there is a occult scleral tear. The IOP is high, then it can be because of traumatic uveitis or because of hyphema. So tonometry will give an idea of what is happening inside the eyeball also, but don't do it unless there's an intact globe or ocular clothes. Before you move on to the eye itself, always look at the periocular tissue. Ecchymosis can be there. You can have a lid laceration. All those things have to be taken into account. And you can have anophthalmos, like you see here with a movement disability, indicating there's a occult floor fracture, which is easily picked up when you try to look at the eyeball movements, extraocular movements. You can pick it up along with the anophthalmos. You may want to suspect there's a floor fracture. So when you have most common thing, what you see is subconjugal hemorrhage. When the superior margin of the subconjugal hemorrhage is not visible, you should suspect severe orbital trauma or intracranial injury. So when you look at when you have a SCH, always look at the upper border. If it is visible, it is okay, it's localized. If it is not visible, you always suspect orbital or intracranial. So always ask for a neuroimaging in these eyes. So sometimes extensive SCH can also mean there's a retrobulbar hemorrhage, especially when it occurs with proptosis. And in these cases, you may have to look at the intraocular pressure and see whether there's a risk of central retinal artery occlusion. In those cases, you may want to do a lateral canthotomy. This may not be issue if you're practicing in a standalone eye clinic, but if you're practicing in a general polyclinic where you're bound to see ocular trauma as a first, this lateral canthotomy can be a vision saving procedure, especially when the eye is severely injured. So when you're doing the anterior segment, first look at the cornea for any corneal tear, injury, all those things. But you also have to look for Descemet's tear. Even though Descemet's tear is very uncommon in adults, it can happen due to shockwave injuries, and this is a case of a pressurized jet of air, which can also cause a TM tear. So pressurized jet or water injuries and shockwave injuries when the high projectile object, especially in blast injuries, passes very close to the cornea, the shock waves can sometimes cause Descemet's tear. So in case of very significant open wounds, there is no need to do a serial test. It may cause infection also. But in case of very occult small perforation where it will be difficult to assess whether it's open, it's a perforating injury or not, then you can do a serial test, and you can put a small bit of fluorescent dye and then see whether it is leaking. So in case of hypotonous eye, unless you exert pressure, the leak may not be visible. So in case of hypotonous eye, always exert a little bit of pressure to see the dye is getting diluted, that by indicating an open wound. Then also it may also pick up iodiolysis, or when you're doing for chemical injuries, always make sure that you look at the whitening of the perilimbal area, which indicates limbal ischemia. So these case, all this have to look to your slit lamp. And when you're waiting for treatment, don't patch in open wound injuries, because a pressure patch can sometimes extrude the intraocular contents. And always put a hard shield rather than a bandage. So bandage can sometimes exert an inordinate eye pressure, causing expulsion of the intraocular contents. So better than putting a bandage, it's always better to put a hard shield to prevent damage to the eyeball or intraocular contents. So in cases where there is intact globe, where there is no obvious cords rupture, then you can do a gonioscopy also to assess the angles. So this is a small gonioscopy showing the presence of cyclodialysis cleft, which can be a reason for post-trauma hypotony. And this is showing an angle recession. So angle recession itself may not always result in glaucoma, but approximately around 10% of people with traumatic angle recession can go in for open angle glaucoma in the coming days. So you have to, when you diagnose angle recession on gonioscopy, keep a close follow-up for post-traumatic glaucoma in the coming weeks to months. So in case where the media is clear enough, you can proceed to do either both the 90-day examination as well as indirect ophthalmoscopy examination. So this may sometimes pick up vitreous hemorrhage, retinal tears and detachments, choroidal rupture, or Berlin's edema. Just showing a few examples of this. Actually, a vitreous base avulsion in a patient with blunt trauma. This is a case of a retinal dialysis in a patient with blunt trauma. You can sometimes you commonly get macular holes, but uncommonly you can get macular tears also, which are much more difficult to manage. This just showing a surgery of a patient with osteogenesis imperfecta, who went on to develop secondary post-traumatic macular tear. You can see a very large macular tear because the retina was very stiff because of intrinsic contracture. We had to do a 360 retinal retinectomy to attach this retina, and she has around 1 to 260 vision following this surgery. So more commonly, what you do see is choroidal rupture with submacular hemorrhage, and this is a very unusual case of chorioretinitis sclerotinia in high velocity injuries like bomb blast injury, especially in well diggers as well as in political violence. I have seen a cases of chorioretinitis sclerotinia in following cricket ball injuries when the ball bounces off the bat, the edge of the bat. So that also I have seen, but it's most commonly seen in blast injuries. You can see there's a simultaneous rupture of the retina, RPE, and choroid, thereby exposing the naked sclera. So it usually does not result in retinal detachment because all the three layers are simultaneously ruptured. So it rarely ends up in retinal detachment, but this is an unusual case. It's a very unusual case where we had a RD following a choroidal sclerotic. I can see the large choroidal sclerotic area, which is almost in the infratemporal quadrant. It's not a choroidal coloboma because that is more seen in the infranasal quadrant, and you can see the secondary tears because of Berlin's edema, just nasal to the area of choroidal sclerotic area. And then we had to do vitrectomy and do laser to those tears secondary to the Berlin's edema. So it's very unusual to see a retinal detachment following a choroidal sclerotic area. And what you more commonly see is the whitening of the retina because of blend trauma, because of photoreceptor damage, which produces whitening color. It's not actual edema; it's a misnomer. It's because of the accumulation of breakdown products of the photoreceptors, which can be seen either in the posterior pole, maybe in a cherry red spot, or it can be seen in the periphery as well, depending upon how the trauma occurred. Also, sometimes apart from this choroidal tear, you can also see a RP contusion injury, which is much more subtle than a choroidal tear and sometimes easily missed, but it can be a cause for subtle vision loss in these blunt trauma eyes. Which is more drastic and more grievous is the optic nerve avulsion. This is again a cricket ball injury where you can see there's extensive whitening of the retina because of ischemia, because of the rupture of the central retinal artery as well. And you can see the cattle trucking of the blood in the vessels, indicate a big pit where the optic nerve should be, along with the optic nerve. You can see the blood clots sitting right on the optic nerve head, which usually indicates a optic nerve avulsion. So when in case of unclear media, then you may have to resort to other imaging modalities, like the commonest being the ultrasound B scan, which can be critical in identifying the posterior segment injury to the posterior segments in the presence of vitreous hemorrhage. It can rule out all these retinal detachment, choroidal detachment, and also pick up intraocular foreign body also. In extensively open wound, always avoid doing a B scan because it can again create pressure and expel the intraocular contents. But in subtle injuries or very small injuries, you can do a very careful ultrasound B scan without pushing on the globe too much. But in large open wounds, better wait till the suturing is done and then you can do the B scan afterwards. Just showing a case of a traumatic vitreous hemorrhage in a patient with the blunt trauma. And sometimes you may, depending upon the clinical signs, you may have to assess whether it's really a vitreous hemorrhage or it's a vitreous inflammation. Is the case of endophthalmitis following a penetrating trauma. So the clinical history and ocular findings will help you to diagnose whether it's just a case of hemorrhage or it's a more grievous case of endophthalmitis. And again, you can see the presence of retinal detachment in patients with the blunt trauma, post-traumatic retinal detachment. And sometimes open wound with hypotony, resulting in hypotony, can produce a serious choroid detachment, which can be picked up in ultrasound. Just suturing the wound and restoring the intraocular pressure will lead to resolution of choroid detachment. You don't need to treat anything extra beyond that in a patient with post-hypotonic choroidal detachment. So sometimes you may be able to pick up dislocated lens. You can see the hydrated dislocated lens in the posterior vitreous following a blunt trauma. So this may be seen as a round to oval shadow on the posterior segment. And when you are diagnosing intraocular foreign bodies, never diagnose intraocular foreign bodies lying in the coats when the eye is hypotenuse, because a scleral tear or corneal tear can cause hypotony with scleral folding, and the double layer of scleral folds can produce a shadow which mimics a intraocular foreign body. So never diagnose intraocular foreign body in a ocular hypertonia eye. So wait till the wound is sutured and then do the ultrasound to confirm the presence of intraocular foreign body. As you can see, intraocular foreign body is seen as a hyperechogenic lesion with the after shadowing behind it, so that you can assess whether, and this can be dealt with once you diagnose, depending on the other associated factors. So it's very unusual to see no perception of light in patients with the trauma. But in case you have a assess that the vision is no perception of light, always assume and rule out optic nerve avulsion. So in media clear eyes, I already showed a picture of optic nerve avulsion, how it looks like. But in most of the cases, they come with significant vitreous hemorrhage, and the only way to assess is ultrasound. In ultrasound, you'll be seeing that the vitreous is incarcerated at the area of the ONH, or you may see a pre-ONH large blood clot, and you can see the normally a conical optic nerve shadow will become more rectangular. They otherwise called as widening of the optic nerve shadow, or it may be also called as squaring of the optic nerve shadow. This may be a cause for this may be pointed towards optic nerve avulsion. So then you have the ultrasound biomicroscopy, which can be used to identify very anterior intraocular foreign bodies, or sometimes cycloidal cleft, which can be caused for post-traumatic hypotony, and sometimes subluxate lens or zonular injury, which may give you findings which may and decide on how to manage this case when you're going up to operate on these eyes. Also, it may tell whether the anterior capsule and posterior capsule intact or not. Just showing some ultrasound pictures of cyclodelsis cleft. You can see the hypoechogenic area between the sclera and the ciliary body, indicating that's the cyclodelsis cleft, which can be a cause for hypotony. And this is some pictures showing the damaged zonules post-traumatic because of the anterior because of the subduction of the lens and the damage to the zonules. And when normally in a UBM, it's very difficult to visualize the lens. You only see a mild reflectivity of the capsule. But if the lens matter is seen, it indicates that the capsule is breached and there's hydration of the intralenticular contents. So that means that you can visualize the lens even more prominently. So whenever you see a prominent lens shadow, then you assume that the capsule is breached and there's hydration of the lenticular substance. Some of the red flags, especially when you see in a severe orbital trauma, when there is sudden drop in vision, when there is a nausea and vomiting, and there's total hypemia, and there's RAPD, that means there's significant retrobulbar hemorrhage. Optic nerve damage because of the compressive. Unless you resort to lateral catheterism within the first 2 to 3 hours, you're going to lose vision in these eyes. This is more dealt with people who are working in a polyclinic, so you may have to do a lateral catheterotomy to save these eyes. And unless you do it within the first 1 to 2 hours, maximum 3 hours, you're usually going to lose the eye. It's a very simple procedure. Any postgraduate should be able to do this. It's a very simple procedure. As you can see, just clip the lateral canthus and go on to rupture the tendons from the bony and the lid should be very freely mobile after complete this, so that the globe can now protrude or propose out of the orbital margin so that the compression is relieved, thereby preventing damage to the circulation. So radio imaging can be either X-ray, CT, or MRI, and you can do this in various indications, just showing a case of foreign body. So this used to do earlier when you were PGs, but nowadays people more lean towards doing CT scan. So this can be helpful, especially you can see a ring is sutured onto the limbus, and then again both anterior, posterior, and lateral X-ray. This is how you do localization. So by keeping your calipers at the edge of the limbal ring, with the 12 millimeter radius, you just draw a line that will indicate the center of the globe. And the center of the globe, you draw one more circle. That's the ocular codes. The foreign body is seen within the ocular codes, within this line. It's inside the ocular globe. If it's outside the ring, it's outside the globe. And if it moves see this nowadays. Also, which can be an indicator of floor fracture. And in case you are doing or a basis indicating 0.5 to 0.1 to 1 millimeter, otherwise you can miss subtle foreign bodies. So when you're dealing with metallic foreign bodies, routine CT can produce a flaying artifact. So thereby, it may be difficult to visualize whether the foreign body is inside the globe or outside the globe. So better you do bone density CT scans when you're dealing with the metallic foreign bodies. That will minimize this flaying artifact, thereby giving a better assessment whether the foreign body is inside the globe or outside the globe. Level of the coats. Again, showing a CT of the floor fracture, you can see the herniation of the orbital of the ocular fat into the maxillary sinus. And this MRI scan, which is not as spectacular as the CT. Again, you can see the herniation of the same floor fracture. So, optic nerve injury can be either direct or indirect, traumatic optic neuropathy. In indirect injury, what you usually see is enhancement of the optic nerve sheath with the echogenicity, hyperreflectivity in the MRI. So, in cases with the indirect injury, just see the hyperreflectivity on MRI. But in seeing with the direct injuries, you can CT, you can always see the broken bone fragments impinging on the optic nerve, and this may indicate that you may need some neurosurgical procedure to relieve the injury because of the impinging bone fragments. If it's just indirect injury, you may have to just treat with the steroids, and if it's impinging direct injury, you may want to do surgery to relieve this injuring bone fragment, remove it. So retrobulbar hemorrhage, as again I told you, can be a cause for vision loss unless treated early. So if you don't have time to do MRI or CT, better do the surgery. The lateral canthectomy is nothing serious. You can do it and you can suture it later also. Whenever it is a delay in diagnosing this, always be ready to do a canthectomy, lateral canthectomy. So anthracyclosis is rarely done nowadays because the newer modalities have come. So we are doing right now. We are doing a few cases. We can do angle recession to assess angle recession. You can see the normal angle on the left side and the recessed angle on the right side. It's more easily seen with the gonioscopy. But if you have the ASOCT, you can do also this and confirm the presence of and again, this ASOCT is showing the presence of cycloteliosis cleft, which can be also picked up on ultrasound biomicroscopy as well. So to conclude, diagnosis in ocular trauma requires systematic, cautious, and timely approach. And clinical examination and appropriate imaging is the key to diagnosing and treating early. So when in doubt, assume an open globe, avoid unnecessary pressure to the globe, especially when you are suspecting an open globe injury, and image early. And keep in mind that the eye you save is often the eye you diagnose correctly. So I'll stop here and we can discuss.
Yes, sir. Saravanan sir, thank you.
Yeah.
Thank you for that excellent presentation. Uh, so I request the panelists also to please pitch in. So Saravanan sir, I had one question before we open up to the panelists. In which set of cases would you go in for one stage surgeries versus two stage surgeries? For example, if you have both the corneal injuries and which requires the vitreous hemorrhage and the retinal detachment, where the corneal tear suturing has to be done and then the VRC intervention has to be done. What would be your choice, as these are the things which I do it under the first stage, and these are the things which I would prefer to do in a two-stage procedure. That is, first is the scleral tear, the corneal tear, and then go in for the RD, because some of them say, most of the trauma surgeons says that it's always better to do a one-stage procedure where you try to secure the sclera, cornea, and then directly go in for the retinal surgery. So, which are your choices for the one stage versus two stage surgeries?
So whenever the wound is not too large, so whenever you have probably three, four indications. One is vitreous hemorrhage, second is retinal detachment, third is dislocated lens, and finally the intraocular foreign body. So whenever the wound is like whenever you are going for a retinal detachment, you have to put in a tamponade. And when there's a large open wound like a corneal tear or scleral tear, that is going to compromise the globe intactness, and there can be leakage of the tamponading agent, either it's gas or oil. So whenever it's not a very critical injury or just a vitreous hemorrhage or a mild retinal detachment, I would usually prefer to close the wound first and then take it up for surgery. Again, intraocular foreign body as well. If the media is clear enough, I try to do it in the first sitting itself. But if the media is not very clear or the very large wound, we first suture the wound, wait for the eye to stabilize a little bit, and then take it off. Take it off for the second step surgery. It all depends upon the extent of the corneal or scleral tear and the clarity of the media. This will decide whether you want to go for a one step procedure or two-step procedure.
Okay, Neeraj sir, I would like you to pitch in here. Say, just in continuation of the same question, the patient had an intraocular foreign body, but it is still sterile, not having any signs of endophthalmitis. I'm sure that in any case of the intraocular foreign body, if there is a case of endophthalmitis, we would definitely all would go in for the one-stage surgery, where try to secure the scleral tear, do the corneal repair, and then immediately go in to reduce the infection. So, how frequently would you like to call these patients who have still not developed endophthalmitis if you want to plan the two-stage surgery? So as sir said, you would like to go in for the primary scleral tear or the wound repair, that is the primary wound repair. And then how frequently you would like to observe to look in for any signs of endophthalmitis, and then go in for the intraocular foreign body removal in the second stage.
Generally, like as Dr. Savan said, we try to repair first the wound itself, whether it is a corneal wound or scleral wound. And in a case of any foreign body, whether it is a sterile or kind of infectious, we try to remove it, whether in the first sitting or the second sitting, because even a sterile foreign body will have some reaction or may not have reaction, but have some mechanical trauma to the eye intraocular when it is moving inside the eye. So, in my opinion, any foreign body which is intraocular should be removed, whether it is sterile or kind of infective or whatever it is. And try to remove in the first go itself if corneal clarity is allowing you to take out the foreign body. If the corneal clarity doesn't allow in the first go, then wait till the cornea is clear and take out the foreign body.
You are muted, sir. You are muted, sir.
Sorry, Sunil sir.
Yes, sir.
After listening to an excellent presentation by Dr. Sarvanan, would like to add anything to what he has already discussed that our dear postgraduates needs to know?
Yes, sir. Sir, thank you, sir. Excellent presentation by Sarvanan, sir. Very concise and comprehensive. So, first of all, we should take the detailed history about the injury and circumstances of the injury. And we should not forget we should not only focus on the eyes. We first also check the vital. Sometimes we forget the examining the patient, systemic examination. So taking the vitals is very, very important. We should check the pulse, BP, and everything in the basic. And on the sometimes patient present with a huge orbital edema or something like that. So in that case, we can use the decimal lead retractor to retract the globe lead and to examine whether it is open globe injury or closed globe injury. And we must differentiate between whether we are dealing with the open globe or closed globe, and then we have to manage accordingly. And also, all these cases are the medical legal, so we have to also think on that line. So taking the detailed history and documentation, every finding is very, very important. And taking the identity of the patient as well is very important, whether it is the assault or it is accidental. So we have to write everything in details. So that is very important. And also from the medical legal point of the view, the diagnostic, the basic diagnostic of the X-ray orbit and penis is required in all cases for the medical legal point of view. And doing ultrasound in open, I see the lots of patients coming from the outside, open globe injury, and what they have done is only ultrasound. But and sir has rightly said, in open globe injury, we should avoid doing the ultrasounds. So that's very important. Yes, sir.
Okay. Yes, Dr. Karnal Saab, you are there?
Yes, I'm there. Please pardon the sound
Yeah,
is
yeah.
disturbing me.
Yeah,
So
please go ahead.
one thing is reverse, which is one of the
Your voice is
changing
breaking, sir. Pradeep sir, your voice is
Some network issue.
here now. So REPD by
Yeah,
reverse.
probably can switch
Relative
off your
afferent
video, sir.
pupillary
It
defect.
will be able to hear your voice better. Can you switch
Okay,
off your
okay.
Yeah, please.
Yeah, I switch off the videos.
And now it's better.
So
yes.
if we do REPD by reverse, yeah. So the point which I was trying to make is that REPD by reverse remains one of the clinching diagnosis when ocular trauma is concerned, because it guides you whether you have optic nerve injury and you need to start IV methylprednisolone at the very beginning. Second thing it tells you is that are you dealing with an orbital compartment syndrome? Because as we see that most of these cases are associated with orbital bone fractures, and you have puffy eyelids and you're not able to open and see the pupil per se in the affected eye. But if you have a reverse RAPD, your mind should be working towards an optic nerve injury or a orbital compartment syndrome, both of which need aggressive treatment. Rest of the things can wait. Another point which I like to make is about the MRI, that whenever we do the MRI, as I saw Sarnan sir's images, they were beautiful, but they were T2 flare images. They did not have contrast. So always try to give contrast so that you are able to make out the choroidal outer coat as well as the optic nerve, which helps you find out where exactly the injury has occurred and whether you need to deal with the optic nerve injury in the present setting. So that were the 2 points I'd like to make in this presentation, and excellent presentation by you, sir.
Thank you, sir. Thank you.
Yes, Dr. Shubham.
Yes, sir. Uh, Actually, that is very odd that someone is asking my opinion on a public stage. But after a very comprehensive presentation by sir, as a young surgeon, I've faced difficulties many a times because of my limited time with retina. So what I've learned is that every case is a new challenge, no matter how trivial the injury might be, or no matter how trivial the trauma might be. Every in You have to be prepared in all ways with all your ammunition, like accessing the retina with a vitreoretinal part, or just managing the corneal wounds, and maybe what you'll change in terms of the phakic status of the lens, and whether you'll remove that. And there are no set rules. I just what I do is, in when I'm operating open globe injuries, my most important uh, parameter is visualization. If the visualization is good, so you can actually go in for small scleral tears, maybe perforating injuries with maybe nail or something, which is very common in our part of the area. So or maybe chip like fabrication things which go into the eye in a projectile way. So we can do it in single sittings because the visualization is good, and if the cornea is clear. Many a times, if the visualization, if the corneal tears or scleral tears are wide, and maybe if as a surgeon I'm going to take more time operating on that part itself, so it won't make sense for me to go and plan a posterior segment intervention also. So you can always live to fight another day, and take it patiently, and always there are mistakes which make you understand what is to be avoided. So trauma is not something that you can only read from books. It is something that you can only experience and enjoy, and as you move forward. Anything else that particularly you want me to ask and
So
talk about?
even in the presence of an intraocular foreign body and infection, sometimes the media may not be clear enough to remove the foreign body. So in those cases, you can just do a blind choroidectomy and give intravitreal antibiotics. And once the eye stabilizes and the inflammation stabilizes and the media becomes more clear, you can even postpone the removal of the intraocular foreign body in cases where there is significant opacification of the media. And as Pradeep sir pointed out, I couldn't get one of the MRIs where we are able to diagnose the posterior scleral tear, and we had to polytrauma with the road traffic accident, and we had to take it up after the initial treatment. So scleral tear can be, especially the posterior occult tear, can be easily missed on ultrasound B scan, especially if there is not much of breach in the ocular cord. Subtle tears can easily missed, but can be picked up on MRI. That's one of the things which Pradeep sir nicely pointed out.
Okay, I just had one point to make it, sir. As Pradeep sir said, I think CT scan of the orbit, the contrast is not usually preferred in the first instance,
First
where
sitting, yes. First
most of the
sitting,
time we do thin
initial,
slices,
yeah,
non-contrast
exactly,
CT is the
exactly.
first line actually to detect any fractures or
Immediate,
IFBs, including the globe ruptures, and avoiding, of course, as you said, due to the metallic foreign body risks, and also the importance of the B scan ultrasonography in the evaluation of the posterior segment like retinal detachment, vitreous hemorrhage. But the only thing is, when you have an occult rupture or a scleral tear, although some people, of course, most of the times we expect them to do X-rays. And of course, in the X-ray, there are different views, I think, which our postgraduates need to know. Rather than directly doing the plain X-ray, which has a limited role, but AP and the lateral skull and the orbital X-rays, that assesses the intraocular as well as the extraocular injuries, the fractures, and the metallic foreign bodies, especially help to localize the high velocity particles when the media opacity obscures any fundus examinations. But still, some surgeons prefer to do a subtle B scan. I don't know where the term has come from, but they try to do a subtle
Gentle,
B
we call
scan
it
without
maybe
pressing.
gentle will be
Huh?
more appropriate. Gentle.
Yeah, gentle or the subtle, whichever some surgeons prefer. So, in which cases do you recommend to do these gentle B scans?
So
You
when
know
there is
that there is a, and what are your precautions to be taken? And in which cases do you say that, okay, these are the cases? Of course, if there is an injury seen, then nobody would try to prefer that. But when the clear cut scleral or the corneal tear injury is not seen, but still you can see the hazy media with the intraocular foreign body, which are the conditions would you like to suggest for this gentle B scan before approaching for the CT or MRI, which might become a slight expensive test for the poor patients?
So anyway, as Sunil sir pointed out, X-ray is a must from the medico-legal point of view. Whether you suspect or not doesn't matter. Tomorrow, if you want to protect yourself from legal implications, better always to do a routine X-ray. So X-ray is more or less mandatory for all cases of trauma, especially from the legal point of view. Rather than you may think that it's a blunt trauma, does not need from the medical point of view, but legal point of view, X-ray is a must. And whenever there is a sealed wound, with the sealed small wounds where there is very less pressure, very less chance of intraocular contents expelling out due to ocular pressure. Because even though you may be gentle, there is always some amount of pressure exerted by the B scan probe when you are trying to do a B scan, irrespective of however gentle you are. So when there is a sealed small wound, you can go ahead with your B scan. But if there is a large or leaky wound, better avoid doing that.
Neeraj sir,
Yeah, I
your
would
view.
like to add, like in my practice, I usually don't order X-ray. I ask for CT scan in case I'm suspecting any intraocular foreign body. I'm not able to pick up on ultrasound, especially sometimes I've seen foreign bodies going into the angle also, which are not being picked up on ultrasound B scan. But yes, there's definitely some wound of entry is there. I'm not able to find out any foreign body. So in those cases, CT scan is of, I think, gold standard in picking up such foreign bodies. MRI, I order only in those cases where RAPD is there and suspecting some optic nerve canal injury and orbital apex something, then MRI, especially if it is not contraindicated in case of any metallic foreign body. Dr. Sarvan, what is your take on like?
You're asking me, sir, yeah.
Yeah, because see, we don't do order X-ray here. We
I
order for
understand,
CT
sir.
scan.
This is totally from the air. The CT is also okay, but totally I'm talking from the medical legal point of view, as probably Sunil Kumar sir can expand on that. So CT is also okay, but in case you are not able to do a CT, at least X-ray is mandatory,
X-ray
even
should be.
though the trauma can appear trivial, because something bad happens, your hands are tied, you may not be able to defend yourself in court.
Yeah, I think the
Sunil
only
sir, you
thing
want to
which a
add?
postgraduate should know is the X-rays high false negative rate for fractures and non-radio opaque bodies. So that is the reason why the X-rays are coming down and the CT is picking up very high. But the only thing our issue, sir, Neeraj sir, is the economics of the patients when they are not affordable for to do the CT, and still how best we can go ahead and identify these foreign bodies so that they can give a clue. And also in the medical legal point of view, rather than doing nothing like a B scan, which mandates, but sometimes because of the scleral tear or the corneal tear, if we don't have it, then I think X-ray still has a certain limited role where we still can perform is what was the discussion. Both the points well
Because
taken.
if you are
Uh,
working in a
Definitely.
government hospital, especially if the CT is overloaded, you may not have time to ask for a CT. Sunil Kumar sir, you have some inputs on this, sir.
Yeah, yes, sir. the X-ray is very essential and basic investigation. And if there is open globe injury, what is we do? We advise the X-ray, and we repair the scleral and corneal tear, and then on the follow-up we do the ultrasound to look for any posterior segment injury or any foreign body. So first we have to tackle the scleral and corneal wound. We have to repair, make the globe watertight, and then we can assess whether there is intraocular foreign body, any posterior segment injury, and then we manage accordingly. So at the first sitting, it is not always necessary to do the CT scan or MRI or anything ultrasound. First, we have to tackle the sclerocorneal wound.
Okay. I think someone wanted to add, Dr. Alpani, you wanted to add something?
Sir, yes, sir. Actually, I'm in very much in favor of doing a B scan because, as sir pointed out, in seal tears, maybe the patient presents to the vitreoretinal people maybe 3 to 4 days after the injury. It has been primarily managed elsewhere and referred to us. So, what I feel is sometimes when there is a total traumatic cataract with a very small scleral wound, so it is a very utility that we can have, that we can do a B scan and rule out whether there is any PC breach or whether there is any gross evidence of any posterior segment abnormality. So one of the very common scenarios is a traumatic total cataract where you just want to operate the patient for cataract and you have to just rule out whether there is any posterior segment pathology or not. So just wanted to add that part.
I asked one of the panelists to please add on the UBM also, the ultrasound biomicroscopy. In which all cases do we do, just as in case of any case of zonular defects or angle recession, ciliary body injuries, which are non-invasive. Anything else which our panelists would like to add a little bit on UBM also, please?
In acute cases, most of the times UBM is not a very mandatory tool. Especially, you cannot do it when you have an open trauma because it includes water bath and cupping, which can cause infection in an open wound, or it can also expel the outs because you have to put a cup. So mainly it is assessful in trying to assess the angle injury. It can be especially foreign bodies at the level of the iris root, ciliary body, or just behind the iris. And sometimes late onset complications as post-traumatic iris cyst. So all those things can be, and also if you want to look at whether the state of the zonules and as well as whether the intactness of the capsule. So this can be easily picked up on UBM. So you can do UBM, especially if the ocular coats are not breached. So that in those cases you can be able to do it actually.
Any panelists want to add anything on this point?
Another situation where I like to point out that UBM becomes helpful when you are seeing hypotenuse maculopathy in a case on fourth or fifth day, and you are not seeing any tear. You can diagnose a ciliary body cleft or a cyclodialysis cleft, and that can help. That can actually be dealt with at the same time, and you can get rid of the hypotony, because again hypotony becomes a sort of emergency, because every couple of days that the hypotonic maculopathy is going to last, you are going to lose vision by a line or so. So there the role of UBM comes in my protocol.
Neeraj boss, anything from your side?
No, I think very important to pick up any like sphenochoroidal cleft and any intraocular foreign body in angle area, because I had a difficult case where a young guy came who had injury around 2 3 weeks back, and we did X-ray. It showed foreign body. We did a CT scan. It was showing foreign body in the angle itself, but due to the paucity of now having UBM, we could not localize that. And during surgery also we had a lot of difficulty in removal because that foreign body was kind of stuck just in the limbal area and it was not visible. So to remove that foreign body was really a challenge. I think anybody can point out like any role of Copi's lenses which glaucoma people use during surgery may be helpful in removal of such kind of foreign body.
Yeah,
I don't have any
definitely.
experience.
Definitely, sir. The Schwann-Jacob lenses and the direct corneal lenses can be used to deal with these cases.
Okay.
Because that was really a challenge. I knew that foreign body is there, but not difficult, not able to localize and see through microscope.
Okay.
And one comment I wanted to ask, like if patient is having post-traumatic suprachoroidal hemorrhage and having PL negative, whether we are going to operate such cases, because I operated 2 cases who were PL negative and they had got back some useful vision.
So
And
in a trauma, no PL is not a contraindication for surgery, sir. This is already dealt with so many published articles that in post-traumatic, especially post-globe injuries, we can go for RD, CD, everything. No PL is never a contraindication for operating on a trauma, post-traumatic cases. Has already been proven with multiple publications, sir. So ample evidence for that.
Okay, before we have another 10 more minutes before we jump into the surgical part.
I can just show one video of this Schwann-Jacob lens in. Can you see my video now? Is it
Not now.
let me
I
hold
think it
on.
came and went off.
Okay. So
Yeah.
this is this you can
Yeah,
see this
it's
still foreign body stuck when just into this. You can visualize that by using this. This is the Schwann-Jacob lens which we are using, and opening up that uveal tissue and then removing it, just showing how a Schwann-Jacob lens can be used to identify. You can see now this is the. You can see that's the foreign body there,
yeah,
stuck in the pars
beautiful.
ciliaris. So you can use the other gonio lenses, direct gonio lenses as well. So whichever is available to you. Just wanted to, for Neeraj sir asked about this, so I'm just showing the use of
Beautiful.
Very nice. Yeah.
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 Please continue, sorry.
Yeah. Thank you, sir. Before we dive deep little, because we have 10 more minutes left. So,
Ah.
the most commonly asked question, the role of steroids in traumatic optic neuropathy. I know if nothing is available, majority of us, some surgeons still prefer giving a dose of oral steroids. Some peripheral practice, they still prefer giving IVMP. I know there is a very limited role according to most of our neurologists, but still I wanted to have an opinion about the role of steroid in case of traumatic optic neuropathies from our panelist. You can stop the screen share,
Oh, sorry, it's
Sarvan.
still
Yeah,
still
no.
sharing. Is it
Srinivas,
still
in case you
sharing?
are suspecting any traumatic optic neuropathy, we give oral steroid, not IV steroid, but at least we give oral steroid.
So
Any
in
other
case of
panelist
yeah,
would like
traumatic
to?
neuropathy,
sir,
even though the standard protocol is to give intravenous
yes, sir.
methylprednisolone, the current evidence is not that very promising.
Because no, most of the neuro-ophthalmologists have stopped giving that, and they say that you should not give the oral steroids in case of traumatic optic neuropathy. It's not going to help. Most of them, there's a lot of debate still going on. So, any difference in the opinion among the panelists? I just wanted to ask. Yes,
Sir,
Pradeep sir. Sorry, Sunil sir, please.
yes, sir. Also, in acute traumatic optic neuropathy, what our practice is to giving the IV methylprednisolone, 1 gram IV daily for 3 days. Then we give the oral steroids because the only treatment option is this only the IV methylprednisolone. So that's we always give, and sometimes we see the good results also. But first we have to rule out any orbital injury, any direct injury. Only in indirect optic neuropathy we can give this.
So there are two logics which I'll like to bring out here. That if in an acute setting you are planning to give steroids, it's either a yes or no option. Once you have decided on a yes, the route of administration should be one which is able to get the molecule close to the site of injury fastest. So it has to be an IV route, and giving IV methylprednisolone does not pose a significantly greater risk compared to oral steroid. So we will always give IV methylprednisolone in such cases.
Sir, your voice is broken.
And during litigation, a question is posed. Apologies, I'll stop the video. I'll stop the video. I hope the voice is clearer
Yeah,
now.
yeah.
So, in case your case goes into litigation, at the time when the judge asks you that what probable cause was there to withhold the medication, then that argument goes against you. I have presented evidence in multiple court cases, and to my whatever evidence we have gathered is not sufficient to deny the patient the advantage of IV steroids in case of acute optic nerve injury. So, with these two things in mind, I will always err towards side of giving IV methylprednisolone than with.
Exactly. So we are not doing any harm by giving IVMP. So only thing is that the evidence is not that very promising. So the mechanisms of indirect injury, one is because of the edema, it's causing compressive optic neuropathy. Second evidence is that maybe one of the theories is that in and around the optic nerve. So if it's a mainly infarction oriented damage, then obviously the IVMP is not going to work. But if it's a more of a edema related compressive mechanism, it may help. But again, we're not doing any harm, so there's no harm in giving, and probably will some patients may improve and it may help also.
Thank you, sir. I think
Completely
there was
agreed,
a
sir.
very varied responses coming to the role of steroid itself. This is what happens in most of the webinars where we are seeing each surgeon have their own protocol. Of course, aiming for the best for the patients. So now, little bit to go in for the surgery in the next 5 minutes. In most of these intraocular foreign bodies, if there is even a large foreign body, I would like to ask the panelists: till what level would you like to restrict doing a scleral wound entry and try to do a lensectomy and try to bring out the foreign body in case of the phakic patients? Because some of them, if it crosses more than 4 millimeter, then they prefer not to do a scleral entry. They prefer to do a lensectomy and try to bring out through either the small incision wound, the scleral wound, or through the corneal wound. So there are different approaches being done. So I would just like to ask if the phakic patients with the intraocular foreign body safely landing in the vitreous with a either with or without detachment, what would be your choice, either to do a scleral wound or in which cases would you prefer to do a lensectomies?
So large foreign bodies, second surgery is that you avoid dropping the foreign body, remove it in one single go. And the chance of removing large foreign bodies or non-magnetic foreign bodies through a sclerotomy greatly decreases if when you're trying to remove it in one single go. And every time it drop, it is going to cause further damage and further vision loss. So in those cases, sacrifice the lens, removed through either the corneal limbal route or the sclerocorneal, scleral tunnel route. So never attempt to remove large foreign bodies and non
Large means how large, sir? What would be your size of
higher
a
chance of
scleral wound
dropping and
entry?
causing more injury. Yeah,
Large means how large? What should be your size? If you, because there has to be some limitation, like you would like to
more
have
than
4 to 5
anything,
millimeter.
anything more than 3 millimeters, I would call as large.
Okay. Any other panelist would like to add anything or their point of view?
No, I think I totally agree with the Saravanan. And one more thing, like in case we are contemplating doing cataract surgery also that time, or the clear lens extraction, we can do the preoperative biometry and put a lens also that time itself. If retina is not detached, and we can put the lens comfortably. Even in detached retina also, with not much of PVR, that can be safely placed. And it is going to give better visual outcome for the patient if the lens is there rather than putting the lens later.
Okay. So if no other point on this topic, then yeah, Dr. Malpani.
It is a very subjective kind of assumption that the size of the foreign body matters. It is the confidence of the surgeon that is
लाइट तो
more
ऑन
important,
किया
what
क्या
I feel. Because sometimes what I feel is when the foreign body is big enough for me to conclude that I may not be able to visualize it clearly when it goes behind the iris and comes out through the sclera. So I would prefer it more through the clear part of the eye where I can visualize it as a whole, so that it does not touch anything elsewhere and it does not create any more problems for the patient.
Okay. Thank you, Dr. Malpani. Use of magnets. So what are the different types of magnets do we use in removing these intraocular foreign bodies?
So you have three types of, rather four types of magnets. One is the rare earth magnet, which so three types. Rare earth magnet, which is the most commonly used. Second is the electromagnet. Electromagnet, you have two types. One is the small electromagnets, which mainly marketed by DORC, which is more or less the suction, the magnetic power is equal to or not more than the rare earth magnet. Then you have the old generation, first generation magnets, which are really powerful, which are no longer used because they cause extensive ocular injury when the foreign body is pulled towards the magnet. So there is no major difference between the magnetic suction power of small electromagnet or the rare earth magnet. Both are equal. So whichever is available in your hand, you can use. But the old generation, first generation large rare earth magnets are present mainly available mainly in the old government hospitals. they are much more traumatic and they are no longer in use.
If any other points from the panelists, please.
As far as the magnet, we are using only rare earth magnets, which are around 20 gauge size only. So, and
Okay.
things can be removed safely any kind of foreign body.
The second last question is the use of the forceps for the interest of the postgraduates. What are the different types of forceps would you like to attempt in uses of removing these foreign bodies, intraocular foreign bodies?
So there is a dearth of good forceps, especially for large foreign bodies. Small foreign bodies, we have the basket forceps and all those things. Recently, Dr. Manish Bapai, who
Manish
bought
Bapai.
Manish
Yeah.
Bapai bought the claw forceps, which is a good alternative. But problem is that the prongs move back and forth when you're trying to grasp. So we need some forceps which works opening and closing happens at the same plane. So that's one of the disadvantages of Bapai forceps. So other things is the Makimer two-prong forceps, which is no longer in production, no longer available commercially. That is one good forceps for removing very large foreign bodies. So a lot of people other have done use the ENT crocodile forceps also for removing. And Dr. Prabhu Bhaskaran from Chennai, he has worked with Epsilon and they are marketing one of his action forceps, which is again two-prong forceps, which works as good as a Makimer. So there are multiple forceps. Right now, we don't have a very all-encompassing single-use forceps that is not available. Probably somebody can design and market that.
Any other points from the panelists would like to add? Okay. Sir, one last question before we end. It's 9 o'clock. Uh, a little more advanced is some surgeons prefer to do not just retinectomy at the area of the adhesion, the retinal incarceration of the adhesion along the choroid, but they also prefer doing choroidectomy as well. So, in which cases, the speaker and the panelist, I want to ask your experience while removing the incarcerated retina at the area when you do along with the retinectomy, and does choroidectomy do or doesn't do any help, plus pros and cons of doing that?
So chorioretinectomy, especially in post-traumatic, that's an injury of the choroid, direct injury of the choroid, because the blood vessels, as a healing response, the blood vessels from the choroid can migrate onto the retinal surface, causing significant retinal proliferation, which can be very difficult to manage. It keeps on growing again and again. So especially when there's a significant injury to the choroid with the exposure of the choroid, or sometimes if you're operating a little bit late, you may already see that blood clot is vascularized. When you try to remove the blood clot, it starts bleeding because not because of the open wound, but because of this vascularized. When you already see vascularization or when there is a significant damage to the choroid, then these are cases which are more prone for proliferation. And especially such an injury near the macula poses a significant threat to vision in the coming weeks and months. So in those cases, you can do a chorioretinectomy, which can be removal of the RP and choroid with cutter, or you can just do a deep cautery, intense cautery. It can be either minimal intense cautery or more aggressive cutting of the and making the sclera white, nude, make the sclera nude. So this mainly depending upon very close to the macula and a significant injury to the choroid.
Excellent. Thank you. Any other last points from Dr. Neeraj, Dr. Pradeep, Dr. Sunil Kumar, sir?
No, I think.
Okay. Great. Dr. Pradeep, all good? Want to add anything?
Yeah,
Last point?
yeah. So I was traveling. I just alighted from the train. Extremely sorry, I missed most of the part. But
No, no.
lovely discussion, and great presentation and discussion by Dr. Saravanan.
Thank you. Thank you. I think, my dear postgraduates and young ophthalmologists, what we are seeing is a very good view post this webinars. We are reaching up to 2,000, 3,000, and sometimes up to 4,000 people participating to review these webinars. We'll try to make a short snippet of these and put it in our ARC channel. Please do watch that. So I would like to thank our panelist, Professor Dr. Sunil Kumar sir, for sparing his time. He's now the director of RIMS Ranchi. Wishing you all the best, sir. Thank you very much for being a
Thank you,
part
sir.
of our ARC program. Dr. Neeraj
Thank you, sir.
Sanduja sir, thank you very much. See you in Delhi very soon.
Thank you.
Thank you, Dr. Pradeep. Even though he was traveling, but he was still available all the time. And Dr. Malpani for your inputs as well. So I'd like to thank our chairman ARC once again and all our member ARC, my colleagues, my dear postgraduates who are watching this. An excellent talk by Dr. Sarvanan. Thank you very much, sir, for sparing your time. And we did a great justice to the topic. And also all the AIS office bearers and the support team, especially Sunil, who is doing an excellent job in most of these webinars, and also Tushar from our ARC team, who has been very helpful and keeping all the speakers coordinated very well. So, with this, we like to end this episode 124. And next week, we'll have our grand entry of episode 125. So, I request all of you to please log in next week. The viewers who are watching this will have a special ceremony on the episode 125. So, see you all soon. Thank you very much. And thank you, all the delegates and the participants for this. Thank you.
Thank you,
Thank you.
Srinivas.
Thank you.
So
Thank you
much.
so
Thank you.
Thank you
much.
for
Thank you so much.
Thank you.